placebo-controlled trial in the early part of the spectrum of diabetes, which really lets us get a very pure look at its efficacy and safety with very limited confounders. Here's the trial design. It's a multi-center, randomized, double-blind, placebo-controlled phase 3A study conducted in 9 countries. It evaluates patients with type 2 diabetes who are inadequately controlled with diet and exercise alone, as reflected by an A1C of 7 to 9.5%. 703 patients were randomized in a 1:1:1:1 ratio to 3 milligrams of oral semaglutide or 7 milligrams or 14 milligrams or placebo. Taking the lessons from the phase 2 study that Melanie described, all patients were started on 3 milligrams who were assigned to the oral semaglutide groups. And they were then dose escalated every 4 weeks until they reached their randomized assigned intervention. This is a 26-week study, and the primary change or endpoint is the change from baseline to week 26 in A1C, with the key secondary endpoint being the change from baseline to week 26 in body weight, with other key secondary endpoints that I will share. Now, new to the PIONEER-1 study is the statistical approach, and I will just briefly comment on it. The statistical approach used in the PIONEER-1 study, and we're probably likely going to hear in future diabetes programs, is based on the FDA 2017 draft guidance. Basically, this guidance introduced the concept of an estimand. Comes from the Latin root. And it basically provides a framework to analyze data and to provide an estimate of treatment effect based on what your scientific question of interest is. So the 2 estimates done in PIONEER-1 were one based on the intention to treat principle, and this is called the treatment policy estimate, evaluating the population level effect, or the second one, the on-treatment principle, which evaluates the treatment efficacy and is also termed now the hypothetical estimate. What is the potential of the drug's effect in the patient? So both have different approaches to the data analyzed. The treatment policy estimate, based on the ITT principle, evaluates the treatment effect of oral semaglutide versus placebo, including the effect of any additional rescue or glucose-lowering medication, and regardless of premature treatment discontinuation. The on-treatment principle focuses on the pure efficacy of those who excluding the effect of rescue, and then assuming that all patients remained on steady medication. Here's the patient disposition. Of the 703 patients, they were followed in the 4 arms. You see a nice completion rate ranging from 92 to 96%. And I think that's important to keep in mind, given the different analytic approaches, because as you can imagine, if it was a low completion rate, that would significantly alter the results based on the different approaches. Here are the baseline characteristics reflective of a monotherapy population, or a population that needs monotherapy. Average age was 55, with an even distribution of male and female. Baseline A1C was 8%, with a type 2 diabetes duration of 3.5 to 3.8 years. Fasting plasma glucose reflected a need for treatment with at about 8.8 to 9 millimoles per liter, and a body mass index was about 32. This is the primary endpoint. On the left, you see the primary endpoint by the intention to treat principle, the treatment policy estimate, and on the right, you see the on-treatment principle, or the hypothetical estimate. And there's a few patterns you'll see. One, the different doses of oral semaglutide are in different shades of blue compared to the placebo in gray. And just like we saw in the phase 2 data, we see a dose-related reduction in A1C, with the greatest reduction seen at the higher doses of oral semaglutide, resulting in a change from baseline A1C of 8% to an observed change down to 6.5% or 6.4%, depending on the analytic approach, by the end of week 26. In addition, you'll see nice consistency between the 2 approaches. This is the same primary endpoint, now looking at the estimated mean change from baseline in A1C at week 26. And here too you see a range of reduction from 3 milligrams to 14 milligrams of oral semaglutide, ranging from about 0.8% down to 1.5%, compared to a placebo change of about 0.1% to 0.3%. All three doses were statistically significantly greater in terms of A1C reduction compared to placebo. Here's the change in body weight, the key secondary endpoint, and a few things to note here. Same thing, intention to treat principal data is on the left, on treatment principal data is on the right. And here again, we see a dose-related reduction in body weight, and it does not appear that we've reached a nadir by week 26, piquing our interest in some of the longer-term studies that we'll report out. Again, you see very consistent patterns and findings between the two statistical approaches. Here it is reflected as an estimated mean change from baseline in body weight, and you see weight reductions of about 1.5 to 4 kilograms with the different doses of oral semaglutide, compared to a reduction in placebo of 1.4 to 1.5 kilograms. Statistically, this was greater at the higher doses, at the on-treatment principle at the 7 and 14 milligram doses, and with the IT relevant targets. We saw the phase 2 data, and we see consistent findings here in the first phase 3 study, and that is that 59 to 80% of patients achieved an A1C target of less than 7% at week 26, compared to a third in placebo. And what about weight loss? Keep in mind, this is not a weight loss study. This is a type 2 diabetes therapeutic study, and here we see that at the higher doses, 7 milligrams and 14 milligrams, you see 28 to 44%. The data I'll present from here on out and in the next session will be all on treatment data for the sake of time and to place in context of previously plasma glucose. And here we see from a baseline of 8.8 millimoles per liter, we have a significant reduction in all three doses down to an end fasting plasma glucose in the high 6s to mid to high 7s, reflecting a change of 0.7 to 2 millimoles per liter compared to a slight increase in placebo. What about safety and tolerability? I'll point out that these are also consistent with the phase 2 data, where we do see an increase in nausea and an increase in vomiting, as we know from GLP-1 receptor agonists, and the highest incidence occurred at the highest dose of oral semaglutide, 14 milligrams, where nausea was 16%. We got the results of the study. The big question is, especially after Dan described the cartwheeling, the ninja warrior antics that these peptides have to do to get across all the multiple barriers to get into the bloodstream. The natural question is this really oral semaglutide in the bloodstream? Is this really having a GLP-1 effect? So this is an indirect comparison between two trials with all the caveats that an indirect comparison would have. But we were trying to gain insight whether this was truly semaglutide in the blood. So I presented to you the data from PIONEER-1 over 26 weeks, starting at a mean baseline of 8%. We looked at the data from SUSTAIN-1, which looked at subcutaneous semaglutide injected once a week at the two doses of 0.5 milligrams once a week or 1 milligram once a week. And here you see that we are within the range of in that 1.3 to 1.5% reduction in PIONEER-1 and in the 1.5 to 1.6 reduction in A1C with SUSTAIN-1. So in the territory, in the range. And same thing for body weight. Keeping in mind this is an indirect comparison. Both populations started at a different body weight, with PIONEER-1 starting at 88 kilograms and SUSTAIN-1 starting at 92 kilograms. Here we see also within the range, at least at the highest dose of oral semaglutide, with a 4 kilogram reduction compared to 1.5 in placebo, and then with subcutaneous semaglutide, 3 to 4.5 kilograms compared to a 1 kilogram reduction in placebo. But then perhaps what would answer it the best for us was actually looking at the average semaglutide concentration at steady state. PIONEER-1 represents the first phase 3 trial data in a randomized multi-center blinded fashion demonstrating significant benefits versus placebo of a first oral GLP-1 receptor analog, oral semaglutide, in glycemic efficacy at all doses, weight loss at higher doses, doses, improvements in fasting plasma glucose at all doses, and achievement of clinically relevant targets, A1C of less than 7%, and a body weight loss at 5% or greater. The safety and tolerability of oral semaglutide was consistent with what we know about the GLP-1 receptor agonist class, with no unexpected safety and tolerability issues, and additional studies across the full spectrum of care in special populations and comparing it to active comparators with varied trial duration have been completed or are completed now in 2018.